Dear students, the next lecture is about the gross anatomy of the male genitalia. The first slide shows the external and the internal genital organs. The red labeled organs are the internal organs, which starts with the male gonad, which is called testis. This is surrounded by the epididymis. Then its continuation is a duct, which leads from outside to the lesser pelvis, and it approaches the retrovesical space, so behind the urinary bladder, and we will see what happens with this duct later. But we see here in the vicinity the seminal vesicle, and then we have a duct after the union of these two structures called ejaculatory duct. We have a pair of the ejaculatory duct in the prostate. This is an important organ in men under the bladder, the prostate, and I think I labeled everything this way, which are in red. You see here the urethra, which comes from the urinary bladder, passing to the prostate and passing through this little skeletal muscle membrane, the urogenital diaphragm or perineal membrane in English, and it enters the penis in the so-called spongy part of the penis, and it runs forward. The penis is in green because it belongs to the external genitalia, having three big erectile bodies, two corpus cavernosum and one corpus spongiosum. This is where the urethra runs, and this, the corpus spongiosum, enlarges and at the end as glans penis. This way, everything was mentioned here. The urinary bladder was mentioned, and one more thing, I like to highlight it immediately in the first slide, the very close vicinity of the rectum with the prostate, and that's why it's logical that we are able to palpate, to test the prostate from the rectum. If we go a little bit more lateral from the midline, we see the vas deferens, how it is reflected from the epididymis, and then it passes through the inguinal canal, entering the lesser pelvis. And here we see the third crossing of the ureter in man, and you see here that the ureter is located behind. And then we have an enlargement of the vas deferens, what I haven't mentioned so far. This is the ampulla, and this unites with the excretory duct of the seminal vesicle. I will mention it several times in my lecture. But they form the ejaculatory duct, and the ejaculatory ducts open into the urethra. Now the first topic, the testis and the epididymis with more details. Testis means testimony, and in plural we call this testes. I cited one Latin sentence, unus testis, nullus testis, so one witness is nothing. But in case of the testis, as a gonad, it doesn't work because even one testis is able to generate sperm cells. The major function this way is the generation of sperm cells, so testis is the factory of the spermatozoa, plus it produces the male androgen, so steroid form of testosterone androgen. It is surrounded by the epididymis, having a head, a body and tail on the posterior and lateral margin of the testis. And the epididymis means over the twins, and so the major function is the storage of the sperm cells created in the testis, and then the maturation of the motility. If we take sample from the head, we are able to see sperm cells moving in a circular manner, but if we take sample from the tail, they are able to move already in a wavy manner as well. The third component of the motility is still missing, will be developed later when the sperm cells are able to move along their longitudinal axis as the bullet. So here just wavy at the end. Now, we see two tiny appendages. One is in green, the other is labeled by blue. The green is the so-called appendix of testis, which is the remnant of the Mullerian duct or paramesonephric duct in male, and the other one is the appendix of epididymis, which is the remnant of the mesonephros. Otherwise, the testis has a superior and inferior margin, pole, upper and lower pole, has a lateral, and the other side would be the medial surface, and it has an anterior and a posterior margin. So the epididymis this way is located posteriorly and a bit laterally on the testis. The pink is the spermatic cord, which includes the vas deferens and also the vessels leading down to the testis. But I will describe this topic later. If we have a section about the testis, we see that it has a quite tight capsule with light blue. This is the tunica albuginea, consists of dense collagenous connective tissue, and this is surrounded by the violet, a duplicate of the violet, which is the innermost covering of the testis, the tunica vaginalis, having a parietal and visceral layer. Because they are from the peritoneum, what I will describe later, it's not surprising that we see mesothelium lining on our slides sometimes above the tunica albuginea. The tunica albuginea otherwise provides septae in the organ, and these units this way are the lobules, and in each lobule we are able to find 1 to 4 seminiferous tubules. These are first contortus, so coiled, at the end become straight, so rectus, and posterior and superiorly they merge, they converge in a quite irregular network called rete testis, and this area of the testis is called mediastinum testis. So it's not related to the term of the mediastinum, what we studied otherwise in the thoracic cavity, it is another mediastinum. And until this point it was the testis, and then the rete testis continues towards the epididymis via the efferent ducts of the testis, but it is already part of the epididymis head. And then from the head we have the major duct of the epididymis called duct of the epididymis, and the head part of the epididymis is the only part of the organ which has both duct types, and the rest in the body, it means, and in the tail we have only the duct of the epididymis. So this is what you have to regard when you see this slide. I have otherwise an exam slide which is obliquely made like this, so it includes even the testis with the seminiferous tubules, the rete testis, the 2 types of the head of the epididymis, efferent ducts and the duct of the epididymis, plus it includes the duct vas deferens as well. You see here the horizontal cut. The 2 testes are separated in the scrotum, which is the outer covering, by the septum, and otherwise posterior and laterally you see the epididymis, and posterior and medial we see the vas deferens inside, together with the vessels around. Now this way we are able to distinguish in the vas deferens 4 parts. One is running along the epididymis on its medial side. This is called epididymic part. Then it runs in the spermatic cord, and in the Latin term this is the funiculus spermaticus, that's why it's called funicular part. Then it passes through the inguinal canal, this is the inguinal part, and at the end, which enters the lesser pelvis, runs under the peritoneum, is called pelvic part. Now in the spermatic cord, which is altogether the vas deferens, vessels, nerves, lymph vessels, together with the coverings, we see these structures. The ductus deferens or vas deferens is the major. It is quite long tube, 40 to 45 centimeters, and we have several arteries from 3 sources. The major, of course, the testicular artery, which supplies the testis, and this is a branch of the abdominal aorta because it's a gonadal artery in man. And we have a tiny artery which supplies the vas deferens, the artery to the vas deferens, or deferential artery. This is a branch of the internal iliac artery. And the third one is the tiniest. This is the cremasteric artery, which is associated to the cremaster muscle, and this is from the inferior epigastric artery. Theoretically, we have all the corresponding veins, but I want to highlight the vein which starts in a quite irregular plexus called pampiniform plexus after this special plant-like formation. And this, when it enters through the inguinal canal into the pelvis, becomes the testicular vein, and on the right side this is drained directly to the inferior vena cava, on the left side first to the left renal vein. Now, the reason why we have this is the cooling system, similar to the refrigerator on the back. We have a very coiled, irregular network, and the bloodstream is slowed down, so that's why we have more heat loss, and that's why we are able to keep the testicles a few degrees less than the core, the body temperature. So, together with the veins we have lymph vessels, and I like to highlight this fact that the primary lymph nodes of the testis is not in the inguinal region, what we may expect first. These are along the large vessels called para-aortic lymph nodes in the clinical practice, or lumbar lymph nodes officially in anatomy. You have to know this, and I want to highlight, especially in the second semester, that if the primary lymph nodes are asked and you don't have any idea, try to think of the venous drainage, because usually the lymph vessels are along the venous veins. And in this case, you see the testicular veins, direct or indirect, are drained to the inferior vena cava, and along we have the para-aortic lymph nodes or lumbar lymph nodes, even if it's far, because the testicles migrated down and invaded the scrotum, but the lymph nodes are left around the region from where they descended. So if somebody has testis cancer, you should irradiate the para-aortic lymph nodes and not the inguinal lymph nodes. We have some nerves in the spermatic cord, the genitofemoral nerve with the genital branch. In men, it has motor fibers, somotomotor fibers as well, for innervating the cremaster muscle. Otherwise, it has sensory for the skin of the scrotum. And it has a sympathetic plexus, which innervates the smooth muscle of the duct system of the male genitalia, including the vas deferens smooth muscle. This is important for the ejaculation. So this is under the control of the sympathetic innervation through the superior hypogastric plexus. And we have not in but on the spermatic cord another nerve from the lumbar plexus, ilioinguinal nerve. This is for the innervation of the scrotum, skin of the scrotum. This corresponds in female to the skin of the major labium. In some cases, we may find a remnant from the finger-like process of the peritoneum. In this case, this is called processus vaginalis, and if the remnant is present, it's called vestigium, or just simply rudimentum of the processus vaginalis. In our slides, this is not present anymore, and of course, everything is embedded into a connective tissue mass, so that's why connective tissue is found. This slide, as you see, because of lots of contents, it's excellent for hunting for the basic elements in histology. So it's a paradise for us on the exam. Now let's see then the formation of the coverings of the testis during the descensus of the testis. Originally, if you look at the layers of the abdominal wall, we see the skin, then the superficial fascia of the abdominal wall. Then we have the three skeletal muscle layers, the external oblique, internal oblique, and the transverse abdominis. Then we have the transverse fascia, and the last one is the parietal layer of the peritoneum. This is what we studied in the wall of the abdominal cavity. As you see in this figure, the testis develops outside the peritoneum, but inside these layers. So when it migrates down, the peritoneum remains always outside, I mean, the testis remains always outside the peritoneum, it would be correct, and otherwise the other layers of the abdominal wall are protruded. And this shows the descent of the testis from the original retroperitoneal position, so extraperitoneal, outside the peritoneum, this position, and this special cord which governs the descensus of the testis is called gubernaculum testis. Gubernaculum testis doesn't have English term. It means the governor of this process. So this will be shrunk during the embryonic life and after hormonal influence, and that's why it pulls down the testicles to the scrotum. So we will see the remnant of the gubernaculum later on the lower end or pole of the scrotum. I mean, testis related to the scrotum. So here you see that the testis already in the proper position, and that's why the testis is outside this peritoneal finger-like process. Later on, this will be obliterated and disappears, and that's why we have only a duplicate here. This will be the innermost covering. This is from the peritoneum, and this is called tunica vaginalis. As you see the other layers, the first, as I told you, the skin, and the second is the superficial fascia. In this case, we call this tunica dartos or dartos fascia. These are not included in the coverings. The first covering is the continuation of the aponeurosis of the external oblique. If you remember, in the inguinal region, we have only aponeurosis. We don't have muscular part from this, and the corresponding fascia will be around. Then the second muscle and the third as well still have muscular part around the inguinal ligament. If you remember, they originate partly from the lateral part of the inguinal ligament, and that's why we may find a muscle around this, the cremaster muscle. Then the blue is the transverse fascia, which forms another fascia around the testis. That is also a part of the coverings. Now this is what you see here. As I told you, the skin of the scrotum and the underlying connective tissue containing otherwise smooth muscles as well for the wrinkles, tunica dartos or dartos fascia are not included in the coverings. The first covering is the continuation of the aponeurosis of the external oblique, called external spermatic fascia or cremasteric fascia. The second one is a muscle, but not so continuous as this figure shows. It's rather just bent. This is the cremaster muscle. This is from the skeletal muscle of the internal oblique, and we teach the transverse abdominis as well. In the previous figure, it wasn't seen this way. And the third, another fascia, the internal spermatic fascia. This is from the transverse fascia, and at the end, this bluish is duplicate, is the tunica vaginalis with parietal and visceral layer. The tunica vaginalis covers just a very tiny part of the testis and partly the head of the epididymis. It explains the herniations as well, the inguinal herniations. You maybe heard about that. Inside we saw this landmark, what the red arrows show. The lateral umbilical fold with the inferior epigastric arterial vein, and laterally to this, originally we had a fossa, the lateral inguinal fossa, medially the medial inguinal fossa. If the protrusion is lateral to the fold, through the lateral inguinal fossa, through the deep inguinal ring, because if we remove the peritoneum, we would find the deep inguinal ring, the inlet of the inguinal canal, then the structures can pass through. This is the indirect herniation. If we pass through here, medial to the lateral fold, umbilical fold, through the medial inguinal fossa, this will be direct. The outlet, otherwise, the same. So where we see the protrusion from outside is through the superficial inguinal ring in both cases, but the start point will be different. And if it's from the medial, then it's shorter, that's why it's called direct. If it's through the lateral, then it's longer, and this is the indirect. Obviously, the indirectly is the more frequent because this is a functional canal, still having the vas deferens and related structures through this. We don't have anything normally through the medial inguinal fossa. So we have direct and indirect herniations. Indirect is longer, but this is more frequent. Now let's go to the testis. It shows, back to the testis, it shows that something painful comes. Of course, we should protect the testis several times if we play, for example, soccer, when we have a special defense before the free kick. Here I have to tell you something about the scrotum rejuvenation or the ball ironing. Of course, not the balls are ironed. The scrotum is smoothened, and there's a special laser surgery which is important for the rebuild collagen, and this process will smoothen the scrotum. And this guy is not from our students, but I read this paper somewhere. He was from Norway, and showing the painful area. He sat on this chair under a shower, and you see some holes, and he didn't realize that one of his balls was through this hole, and accidentally he opened the cold water, and reflex-like movement, upward jumping, but his ball left under the chair. So it's not the best way to elongate your scrotum. Now, anyway, I just wanted to tell this, but I wanted to show this. I like this advertisement in an American paper somewhere that you can make the scrotum so shiny after the smoothing, after the ironing, that it becomes so shiny as the Christmas ornaments. Christmas is coming soon, so that's why I did this description. Next is more important after this joke, the prostate and seminal vesicle. And this is a very important situation, the retrovesical situation, which shows the urinary bladder from behind. So from the aspect of the rectum, it means. That's why from the rectum we are able to palpate this area quite well. So this is the prostate below, and we see here the vas deferens, which is crossed by the ureter, and this is the third crossing in men again. Ureter is behind, and its final enlargement is called ampulla, and this unites on each side with the excretory duct, which is this, of the seminal vesicle. Seminal vesicle is located more lateral than the vas deferens ampulla, and the tip may reach the ureters. And here you see maybe that these two on each side will unite, and they form the ejaculatory duct. So that's why we have one pair of ejaculatory ducts. And this happens, this union, in the prostate. Otherwise, below we see an important skeletal muscle, the transversus perineum profundus, with its two fascia layers above and below, called together urogenital diaphragm or perineal membrane. This is the second layer of the pelvic muscles. And this is where, from below, the bulbo-urethral gland, the Cooper's gland, are embedded. Otherwise, they open into the urethra. This is still from posterior view. We see the same. If we remove a very important fascia septum, connective tissue septum, the Denon-Villiers fascia in clinical practice, rectovesical fascia, otherwise, or septum, I will mention it later. We see this picture. Laterally the seminal vesicle, medially the ampulla of the vas deferens after the crossing. And you see the excretory duct of the seminal vesicle unites with the ampulla of the vas deferens to form the ejaculatory duct. This is already in the prostate. And what you see here is the peritoneum lining, which is over the bladder. That's why everything what we described are in infraperitoneal position. If we remove the posterior surface of the prostate, so still a posterior view, we see this union between these structures, what I mentioned several times. Let me skip it now. And between them we have a third one, what I haven't mentioned. This is the prostatic utricle, also called male uterus or male vagina. It is supposed that it develops from the distalmost part of the Mullerian duct, And maybe this explains why in several men this is a sensitive area. This corresponds to the male G point. When I studied this, it was mentioned that this prostatic utricle develops from the distal part of the Mullerian duct or paramesonephric duct, but then I heard that approximately 15 years ago, gene expression studies showed that this is rather from endoderm of the urogenital diaphragm, of the urogenital sinus, but it seems now that again it's rather from the Mullerian duct, so probably I hope both will be accepted on the exam. This is important frontal cut. This is the urinary bladder again, and under the bladder we see the prostate. You see the urethra passes through. We will study the parts of the urethra later. We watch this from front in this case, and we see on the posterior surface of the urethra a little elevation labeled in green. I return to this later, but this will be the seminal colliculus. And you see what muscles and in general what structures under the peritoneum are in the vicinity of the prostate. So this is the peritoneum. That's why everything here would be in the infra or subperitoneal space. You see here quite dense vascular network, venous network called prostatic venous plexus. And what I want to highlight is that we have two skeletal muscles in the vicinity. One is this oblique one, levator ani, with its two fascial layers above and below called pelvic diaphragm. And the upper fascia of the pelvic diaphragm is reflected on the prostate and forms a capsule-like structure around the prostate. In histology, we don't teach any capsule on the prostate, but from a clinical aspect it's quite important because in case of the cancer we have much worse prognosis if the cancer cells invade the capsule-like covering and spread to the subperitoneal cavity. That's why we have to know this, and in the clinical practice it would be important for the staging of the prostatic cancer. And we have another skeletal muscle below, transversely, the deep transverse perineal muscle or transversus perineal profundus, with its two fascial layers, again above and below, called together urogenital diaphragm or perineal membrane. And this supports the whole from below, the prostate. And as you see it, it surrounds the urethra, because urethra passes through the prostate, then through this membrane, and this is where the transversus perineal profundus is able to form with its innermost part a sphincter, and this is the external urethral sphincter, or just simply sphincter urethrae. And then the distal part of the urethra will enter the longest part, the spongy part, but it is out of the plane, that's why we don't see this. But you see a third layer of perineal muscles under this diaphragm, related to erectile bodies, what we study later. On both sides we have the crus of the penis, these bluish, surrounded by the ischiocavernosus muscle, and around the urethra we have the bulbous penis, surrounded by the bulbospongiosus. I will return to this later when I describe the gross anatomy of the penis. If we watch from front again, this area with larger magnification, the green, we see an elevation of the posterior wall towards the lumen of the prostate. That's why it makes it crescent shape or demilung shape. We have one slide about this. This elevation from behind is called seminal colliculus or verumontanum. It's quite important. We see three openings. In the middle, which is unpaired, is the prostatic utricle, and we have two for the ejaculatory ducts. Otherwise, we see that we have a fold above coming from the trigone of the bladder, the vesicle trigone. This is the uvula of the bladder, and it continues downward as the urethral crest. So we have other folds or other elevations, but this is the largest. And this is where we have three big openings, plus we have tiny openings because of the glands, and we see significant glands lateral to the seminal collicles as well. We will see what kind of glands open into this region in histology. The trigon of the bladder is a very special part of the bladder in development. This is the only one which is from mesoderm originally, compared to the rest of the bladder epithelial lining at least, which is from the endoderm of the urogenital sinus. And if I enlarge this triangle here on the right side, we see the position of the prostate. Again, under the urinary bladder, you see it quite clearly. And from a clinical aspect, it can be divided into several lobes. The anterior part, anterior to the urethra, is called isthmus. Otherwise, we have medial, lateral, and posterior lobe. Close to the midline, we see only the medial and the posterior lobe. And we see tiny structures opening into this urethra. The ejaculative duct, it is out of the plane, so close to the midline. And we see behind the seminal vesicle as well. And this is what we studied, that the excretory duct of this fuses with the ampulla of the vas deferens, then they form the ejaculative duct, so they open from behind. And in one of our slides, we don't see these ducts in this slide because probably it was made under this opening, so that's why we don't see the ducts. Can be a nice question in the exam regarding the level of the section. And prostatic utricle is in the midline, is a pouch, as I told you. We described this. Otherwise, the prostate is a 4 times 2 times 3 centimeter big structure, having a wider part above, under the bladder. This is the base. And below we have the apex, which is resting on this urogenital diaphragm or transversus perineae profundus. The blood supply is related to the inferior vesical artery, which is a branch of the internal iliac artery. And I mentioned already earlier the dense plexus, venous plexus around the prostatic venous plexus. This is drained to the internal iliac vein as the artery. Gives this branch, it means. And that's why the lymph nodes, the primary lymph nodes, I told you the rule a few minutes ago, you have to regard the venous drainage, it is related to the internal iliac vein. That's why the primary lymph nodes are to the internal iliac lymph nodes, mainly. We have also sympathetic innervation because the whole prostate, we will see this in histology, is a smooth muscle, mixture of smooth muscle and connective tissue elements. And the smooth muscle should be innervated, and this is under the sympathetic control. So it is also related to the ejaculation. We have to release all the secretions from the glands into the urethra. Now we have other structures here what I want to highlight. For example, this is the reflection of the peritoneum, which comes from the bladder, so that's why the bladder is infraperitoneal as well, and reflected to the rectum. This is the rectovesical pouch. In men, this is the deepest point of the peritoneal cavity. We have a very important septum in green now, which separates the rectum from the seminal vesicle, let's say. This is the rectovesical septum. This is the Denon-Villiers fascia in clinical practice. It's quite tightly attached to the seminal vesicle, so when somebody operates and wants to remove it, it may hurt easily the seminal vesicle, I heard from urologist. And behind we have the rectum. I like to highlight the vicinity of the rectum with the organs, especially the prostate, can be palpated from this direction. And in front, between the symphysis and the prostate, we have the puboprostatic ligaments. Sometimes it may have some sympathetic elements, the smooth muscle elements called puboprostatic muscle. Once I dissected this, it was quite hard work because I need to use a special headlight to see the deep structures under the bladder. We don't touch usually this area already under the bladder. We have two arches which connect the prostate to the symphysis to give a stability. And we have the urogenital diaphragm with the transversus perineae profundus muscle, and around the urethra this forms the external urethral sphincter. In English, this membrane is called perineal membrane. That's why the urethra which passes through is called membranous part. And we have the bulbourethral gland from below, which is embedded in this membrane. We mentioned this earlier. And at the end, I like to highlight a very important center in the male perineum, the centrum tendinum in Latin, or in English terminology, the perineal body. This is where all the perineal muscles are united, almost. Even the external anal sphincter from behind, the bulbospongiosus, from above the transverse perineum profundus, from lateral direction a bit the levator ani as well, and we have a third one, the transverse perineum superficialis. So basically the only one regarding the perineal muscles which are not related to the center. To the center is the ischiocavernosus. At the end, I like to highlight this vicinity of the rectum to the prostate. That's why we were to palpate, and this is a very basic examination in case of men in urology to start if you want to examine the male genitalia from behind, from the prostate, because of malformations, cancer, or any other enlargement can be palpated quite well. And at the end, let me tell something. Some people like to have this digital examination. I mean, the stimulation of the so-called G point, as I told you, within the prostate. At least this is a theory. And I heard about a patient who preferred to visit doctors to have rectoscope examination. And one of my friends who became a urologist told me another case when he successfully operated this other, metal tube from the rectum for auto stimulation, let's say. This was Rexona for men. Okay, thank you very much for your attention. I will continue later with histology of this topic.